Welcome to ACOG's Video History Project. We're very, very fortunate today that we have one of the most outstanding OBGYNs of our specialty, Dr. Alan Decherny, currently working at NIH. And Alan has agreed to come in and tell us a little bit about his views on medicine as we see it today, and specifically OBGYN. Alan, thank you very much.
Well, thank you for having me.
Oh, we're most pleased. Having known you for so many years, now I get to really explore you.
Great.
Let's start out and tell us a little bit about your early history. Where were you born and raised?
I was born and raised in Philadelphia, in South Philadelphia. My father was a family practitioner. He lived and practiced 2 blocks from where he grew up. I then went to college at Muhlenberg College. I wanted to be a doctor. I was not a great high school student, and Muhlenberg College guaranteed that you'd get into medical school. What they didn't tell you is that they took 100 pre-meds, 10 pre-meds graduated. Those 10 got in. I was one of the 10. I then went to Temple Medical School, where my father was a graduate, his brother, a psychiatrist, was a graduate, and their uncle was the head of ENT. After medical school, I was a resident at the University of Pennsylvania Hospital, where Luigi Mastriani was the chairman. And it's at that point that I developed an interest in endocrinology, reproductive endocrinology.
We'll get back to that. Let me go back. Why did you decide you wanted to be a doctor? Was it because of your father, or was it something else?
I never considered anything else. As far back as I can remember, I wanted to be a doctor because of my father. We lived with the practice. So we lived upstairs. The practice was on the first floor. We lived on the second floor. And I don't know, it was never pressure on the part of my parents. My parents never pressured me. And it's just something that I wanted. I never even thought of anything else. And in fact, the only time I ever wavered is that my uncle was a psychiatrist who was my favorite relative. I wavered from going into OBGYN and perhaps going into psychiatry, but that was it. But so that's always what I wanted to do.
Well, there's a fair amount of psychiatry in OBGYN.
That's true. It's part of the reason I think that I picked it.
Okay, let's go back now.
So I went to Penn as a resident. I should say before I went to Penn, I went to the University of Pittsburgh for 1 year as a medical intern. At that time, it was required that you took a year before your residency. I took a medical internship. And then during that time, I considered going into medicine, but I missed surgery. So about 2 months into my internship, I decided medicine was not really what I wanted to do, internal medicine. I wanted to do surgery. And I thought of all the different kinds of surgery, and the thing that I liked the best was OBGYN, because you did surgery, but you also had continuity of care. You didn't operate on somebody's brain and never see them again or see them once a year. So that's why I went, so then I interviewed at Harvard, Columbia, and the University of Pennsylvania. Duncan Reed interviewed me at Harvard and offered me the job, but I didn't like the job there because you didn't go through as a group. They took a new resident every three months, so there wasn't a group. I interviewed with Jack Chiara at Columbia, but he was leaving, and I actually interviewed at Yale with Quilligan, and he was leaving. And then I had a terrible interview at Penn, and I wasn't interested at all. But then Luigi called me up a couple weeks later and said, "Come on back, give us a second chance." And he met me at the airport and spent the whole day for me, and that's how I wound up. That's how I wound up there. Then at the end of that, I went into the Army for 2 years because of the Berry Plan. Vietnam was long over. But the Berry Plan, I signed up when I was in medical school, and we went to Tokyo, Japan for 2 years, which was a wonderful experience. I didn't know what I wanted to do when I came back, and I couldn't negotiate for a job, so I took a temporary job at Yale running the Women's Health Service. Well, the temporary job turned out to be 17 years, and while I was there, Spiroff left after 6 months, and Case left after a year. And because I was a skilled tubal surgeon, I had no knowledge of endocrinology, of reproductive endocrine. I inherited their practices, and I became the division head of reproductive endocrine. I studied with Case. I used to go to Case's house every Saturday and Sunday, and I did the copywriting on his second edition of their textbook, and we sat around the pool, and if I had a question, he'd answer the question. Obviously, I passed the boards and became the division head, and I was there for 17 years.
That's an interesting way to move into reproductive endocrinology.
Yeah, I never had a fellowship. Never had a formal fellowship.
Well, but around that time, that wasn't necessary, was it?
No, not at all. In fact, the year that I took the boards, it was the last year you could take it as a grandfather, and I think about 80 people were grandfathers that took without a fellowship, that took the boards at that time.
All right, now you were at Yale. I remember you at Yale, and that was a very prestigious position. But then you left.
Well, I was there for 17 years, like I said, running the division, and they recruited me to Tufts to be the chairman. I had looked at two other chairmanships before. One was at the University of Pittsburgh, and one was at the Mass General. But I didn't feel that I was ready to be a chairman. I too many other things I did. I loved being a division head. I had a great fellowship. So I really wasn't ready to move. But Tufts seemed like the right time. It was an interesting challenge because Tufts was a unique medical school. They were ahead of the curve as far as managed care. They had a fixed faculty. They had a fixed patient base. So they had their own health plan. And so we went there, and it turned out to be a great 5 years. I was only there for 5 years because then UCLA came along and offered me the chairmanship there, and we went there because it was a challenge. Our last child had left the house, so we were an empty nester, so we didn't have to consider our children's education, and it was a different culture. California is a different culture than the East Coast totally. It was a much bigger department. The challenges were bigger, so we went there for 10 years. Also a happy 10 years, a productive 10 years. We had a great time. Actually, my wife, it's the one place she didn't want to leave. She did, though, and that worked out okay. But then I was offered this job at the NIH, which is a unique job.
Well, tell us about the NIH job.
Well, I did this every 4 years. They do a site visit. And I was the site visitor before I came here, and that's how they recruited me, because we made many changes. So actually, one of the reasons I came here is because I didn't want to be a chairman anymore, because the administrative burden and the financial burden of being a chairman became too important part of the job. Well, that was a failure, because I still have lots of administrative responsibility. I still have a budget to meet my budget. But it's a wonderful place. The NIH is a wonderful place. They're very smart people, very dedicated people, and we see tremendous, very interesting patients. Nobody sees the patients we do. And we have the biggest fellowship in the country. We have 9 fellows, 3 a year. We also cover the Walter Reed service, and we also cover Shady Grove, which is the largest private IVF center here in the United States, doing the most cycles. My job there is that I'm a branch chief. A branch chief is equivalent in title to a chairman of a department. And we have various attendings that do different things. We have PhDs that work for us. So it's like a very upscale academic division of reproductive endocrinology. Up until now, so I've been there 10 years, up until now I had adrenal disease as well, Cushing's and pheochromocytoma, but we're reorganizing things, so I think that will go to another part of NSEHD.
Well, let's go back to talk about the NSEHD and your particular role in it. I know that a lot of people were surprised when you took the position. I know you know they were surprised because it was felt to be more prestigious to be at UCLA. So what was really made you want to make that change?
Well, it's mainly because of the interest and a different job. There are many UCLAs and many chairmanships, but NIH is very different. It was a challenge. I mean, I knew very little genetics, and this is an institute that primarily does genetics and genetic research. So it was the challenge. I mean, also we're from the East Coast, and we have children and grandchildren in Philadelphia, so that was a small part of the pool, but wasn't the entire part. But it was, and most people that think that I went to the NIH and it was different is they thought I wouldn't do clinical work anymore, but it's not true. I see patients every day. In fact, I see more patients than any other physician at the NIH. So I still see patients. I still operate every Friday, and I did OB until October last year at Walter Reed. I covered the two nights a month, and I'll tell you why I stopped, and it'll give you some insight into what's happened to medicine. Two of the residents complained that I would keep them up at night. They were night floats, and when I'm on call, I stay up all night. And that's part of the reason I went into OB, I think, because I love staying up all night. I get a high from staying up all night. Now they stay up all night, cover the labor floor, they go home. I, who am an older guy, I walk across the street and have to work a full day. So when they said they didn't like the idea, because if nobody was in labor at 2 o'clock, I woke everybody up for chart rounds. Because they were there to learn. That's their best time to learn obstetrics. So I just increased my operating time a little bit. So I'm sorry I gave up OB. I liked OB a lot. I liked thinking on your feet. I liked the relationship with the patients. In fact, at Yale and Tufts and UCLA, I had a private OB practice. I limited it to only 5 deliveries a month because I travel, and I tried to fit it into my travel schedule. But I did private OB up until the time that I came to the NIH.
Let's go back and talk about your experience with the students that didn't want to get up to learn. Tell me what you see as the difference in the student today versus the student when you and I were looking at 120-hour day a week work.
Well, the most important thing when we talk about this is we don't want to be grumpy old men. So it's hard to be objective and talk about the good old days, but it is different. Every generation says the next generation is bad and they can't measure up to us, but I think that there's a big difference. The millennials are very different in that they don't want to work as hard, and especially in our field, especially in reproductive endocrine, because they're only interested in doing IVF. They're not interested in doing more challenging things. Money becomes a big issue. Now I know they have different financial burdens than we had, and I think that's important. But I just think it's they want to know more and more about less and less, and I think that's a major difference in how they spend their time. The other thing is they're very addicted to electronic things, and I think that's also bad because I think the electronic record doesn't allow people to take care of patients. They're talking to the record. Or their computer screen, and I don't allow electronic devices in my rounds because it's been shown that people look stuff up, they don't remember what they looked up, and nobody else benefits from what they looked up because they blurted it out. Their learning has to be somewhat interactive. So I think that this, yes, they'll be fine, and when I get older and I need a doctor, I'm sure the doctors will be great because the technology is fabulous. But I think that it's not the same kind of calling it was for us.
Do your students have to take call other than the night float?
Well, the residents at Walter Reed do. They work every fourth night. My fellows, they're on. Well, I take 90% of the call for RE. At the NIH as the attending, and I have a fellow on with me all month. But the calls are frequent, but the having to come in is not so frequent because we have very few emergencies.
To most of our members, NIH is looked at as primarily a research facility. Tell me a little bit about the type of patients and how you envision your role in NIH there. Okay,
we see 3 kinds of patients. One, we see patients that are from other institutes that have other diseases that need gynecologic consult. It might be for birth control pills for somebody with a bleeding disorder. And we also have a very, very active fertility preservation program where people that are going to go, young women, the majority are younger than 20, are going to undergo chemotherapy. We freeze their eggs so that they can get pregnant later on. So that's one group of patients. Then we have a referral practice for very odd patients with reproductive problems. Patients with rare chromosomal abnormalities. A piece of the Y chromosome is broken off and shows up in the chromosome number 8, and the male or female presents with infertility. Adult onset adrenal genital syndrome with rare chromosomal or genetic abnormalities. We see those kind of patients as well. And then we have a teaching protocol where we teach the fellows to do ovulation induction, some kind of surgery, reproductive surgery, robotic surgery. So we see those all three kinds of patients. So we see referral patients from other institutes, we see referral patients just to us, and then we see some patients that just need care that are just teaching cases.
And how do these patients get to you?
Well, anyone can come to the NIH from anywhere in the world, and in many cases even the transportation is paid, and we have a lodge where the family or the support person can stay, and the way they get there is that they have something that we're interested in. So if you're in the Diabetic Institute, NIDDK, and you have a rare form of diabetes, you're making an abnormal form of insulin that, although it shows up as insulin in your assay, it doesn't work at the cell membrane as insulin. We would see somebody like that. And for us, it would be some rare form of infertility, a piece of the Y chromosome that's missing, so the man is azospermic. We have an active laboratory looking at the zona pellucida and the interaction of sperm with the zona pellucida. The third group of patients are patients that are either part of the NIH family or the Walter Reed family or the Greater DC, Virginia, Maryland, that have not a real tough problem, but a little bit that the outside groups are not interested in taking care of them. Now, it brings us up to a little bit to what we talked about, how things have changed in the field. We do a fair amount of surgery for patients that need it prior to IVF or people with a uterine septum, because the physicians don't want to do those cases in private practice because it's not lucrative enough for them. They'd rather see an IVF patient rather than spend time doing their surgery. So we do a fair amount of referral surgery as well. Now that's kind of a mean-spirited thing to say, but it's an interview, we'll be honest.
Well, we want to be honest. And actually, you're one of the few people we've had the opportunity to interview from NIH, so you're giving our viewers, when they look at it, a real insight into the NIH.
Well, let me explain something else about the NIH that most people don't understand. The NIH is divided into two parts. There's an extramural part and an intramural part. The extramural part is what everybody knows. That's the granting people. And that's the 90% of the budget. There's a $33 billion budget. 90% goes to extramural. So that's a grant to the University of Pennsylvania or the University of Hawaii to study something. Then there's where I work. That's the intramural program, up the road a little bit in Bethesda, Maryland. There are 17 institutes, actually 17 buildings that are there, and it's like the Rockefeller. It's a research institute. Yes, there's a hospital there. There's a 250-bed hospital where we hospitalize patients, and there's a clinic that sees about 100,000 patients a year, which is the clinical piece, but of course there are multiple, there's one building just to develop vaccines. So it's also a research university as well. And most people don't know that about the NIH. They either know very little about it, or they only know about the extramural, the funding piece.
We know, those of us in the field, know about the NIH and the NIH research. What do you see as the prime goal of NIH research in your division?
Well, two sides to that question. The leadership sees the goal looking at basic science, very basic science. looking at the yeast genetics and applying that to clinical care, which is far down the line. What I like to think about what we do is translational science, looking at things in the IVF laboratory and transferring that to clinical care. So here's a field 30 years ago, IVF, that had a 5% success rate. Because of changes in the laboratory primarily, because there's no new ways to induce ovulation. Yes, there are new ways, but it's not much different than what was available 30 years ago. So it's the laboratory that's made the big difference. Laboratory is basic science. So that's my goal. My goal is to do science that's applicable to patient care, making better embryos, diagnosing better embryos, making the media better, helping patients with that have fertility problems. So that's the main thrust of what we do. We've had some projects with endometriosis, but that's a little bit tougher. We have a big project with fibroids, and brings up another aspect is that we're very responsive to the Congress. The Congress is very involved in IVF because they go back in NIH because they go back to their constituency and say we gave $3 billion extra to the NIH, and they're working on fibroids, they're working on diabetes, they're working on healing fracture growth hormones to make your fractures. That's because that's what they want to tell. They don't go back and say we're working on the zebrafish and looking at the same genes in the zebrafish that are early development that can be transposed to information about humans. The public is not interested in that. They're interested in what are you doing today that's going to help cure us, and what could be more specific than Biden's big movement now to cure cancer. And that's really the biggest part of what not we do, but what NIH does, the National Cancer Institute, is ability to cure cancer. Personalized medicine is what they specialize in, and that's finding areas in a change, in a metabolic change or a genetic train or genetic chain, where they can interrupt that so that the cancer is cured or controlled.
Let's take you now into the future a little bit. What do you see are some of the major future developments in reproductive endocrinology that we will see maybe 20 to 50 years from now?
It's all genetics. It's going to be, the goal is to develop or only put back perfect embryos. It's not going to be perfect embryos, of course, because nobody's perfect, to use the cliche, but it will be treating embryos with genetic engineering. CRISPR is a good example now, where you can splice chromosomes, take out a piece of a gene that's not good, and put that genetic material, put that new genetic material in. So it will be genetic engineering. They'll be making better embryos, disease-free embryos. So that's what the future is. And in fact, I have my fellowship now is I take 3 fellows. Each year, one fellow will spend 2 years in reproductive endocrine and 2 years in genetics. Because if we don't understand genetics, not only reproductive endocrine people, but if the average obstetrician and perinatologist don't understand genetics, we're gonna have to give that up to the pediatricians, and that's going to be a major part of what we do. I spoke to the University of Pittsburgh Law School a couple weeks ago, and I talked about mitochondrial transfer, but there were a lot of genetic counselors that came, and I said, it's very important that doctors know a lot about genetics because they have to counsel their patients. And they said, no, they don't have to know anything. We counsel the patients. I said, no, you don't counsel the patients. You give the patients information. The patients take that information and they come to the doctor with that information. Or if I'm dealing with a patient looking at her embryo, it's been the embryo's there are 5 embryos and they've been sequenced, and I know what each of those embryos, the potential is for those embryos, I'm the one that has to help the patient come to that decision. And you can't turf it to the patient. The patient has less information than the genetic counselor. So I think that's going to be a big part of what we do. It's going to be genetics in all aspects. I mean, the average obstetrician is going to have to deal with free DNA as far as what do you tell the couple about their offspring. And I'm sure that everybody, because the sequencing gets cheaper and cheaper as the technology gets better, every baby is going to have to be, or every embryo will be sequenced eventually. So I think that's the future. I wouldn't put a lot of my money or time into developing new drugs. I don't think that's going to be helpful. I'm not so sure diagnostic tests will be helpful.
When you say new drugs, what about newer contraceptions that are safer?
Well, yeah, I think, I mainly speaking about infertility. I think that's true. I think there will be better contraceptives for people, especially for women. I don't think there's much promise for male contraceptives, but I do think there'll be better contraceptives for women. And look, it might be John Rock prediction that people would be on birth control pills or some form of contraception continually. They'd have no periods, and except when they wanted to get pregnant, they would stop the contraception and maybe take a fertility pill at that time, or a fertility injection, and the women would not have periods anymore. So that's not so obscure now. So I think that's true. So I think contraception, although there's very little interest in it because what we have is pretty good now, I do think that there will be other things that come along.
You think the role of contraception and non-contraception is going to be still remain with the OBGYN, or do we see a new specialty emerging someplace in the future?
Well, we have the family planning specialty. It is part of us. The field's been challenged by many different subgroups, the midwives, family planning people, internal medicine people doing reproductive endocrine, surgeons doing GYN, oncology. But I'm optimistic about the field. I don't think the field will disappear. Neither of my children went into medicine, but if they wanted to go into OBGYN, I would not discourage them. I think it's a great field. I think it has a great future, and there's no field like it where you have continuity of care with families, which I think is terrific.
I agree with you 100%. And listen, let me thank you for willing to come and talk to us and explain to us the NIH, but more important, tell us who Alan Decherny really is. And as I said when we started, you are a giant in our specialty, and it's been my pleasure to know you all these years.
Well, thank you.
Thank you very much.
Same here.